Hi, welcome to the IEEE IROS2020 RoPat Workshop on Robot-Assisted Medical Training. I'm Florence Leong, a postdoc research associate at Morph Lab, Imperial College London. Today I have Dr. Dhan Thiruchelvam from Australia. He is an upper GI and bariatric surgeon from Newcastle Private. We have a close collaboration in magnetic-based abdominal robotic surgery back in the University of Melbourne a couple of years ago. Hi, Dr. Dhan. It is great to see you, and it is such an honor having you with us today. Thank you so much for joining us. First of all, let's start with an introduction of yourself.
Yes, so thanks, Florence. Look, I've had an interest in robotics for quite a while now, just with initially the Da Vinci platform that we use in laparoscopic surgery. So my sort of background is basically trained initially in general surgery and then in upper GI and bariatric surgery, using a lot of laparoscopic surgery. So that's the keyhole surgery. And that sort of keyhole surgery lends itself to the use of robots. So my interest kind of initially sparked with the Da Vinci and then thinking about models of how we move forward. I mean, certainly whatever the way in which we practice surgery now in 2020 will be quite different in 2030 and 2040. And most certainly robots can help us in many ways in the field of surgery. So that's just a little bit of my background. Yeah.
That's great. So would you like to share with us the challenges that you faced when you were a trainee physician or as a trainer?
Yeah. So look, I guess that some of those challenges are, and this is where robotics may come in quite handy, is that when you're training, you're observing a surgeon at one point in time, and then you're spending time with another surgeon and you're learning their techniques, and you're trying to take in a lot of information at once. So patient position, instrument position, torque, tension, all of those things. And so they're what makes training stressful. So training is stressful because, one, it's unknown, you haven't done it or seen it before, you're doing it under guidance, there's multiple levels of learning. And so I think that also then extends to when you're training people. So I've been a consultant surgeon now for 12 years, and as I train people, again, I see where they get stressed or it's difficult is learning the step-by-step parts to the operation and putting it all together. So this is where I think, robotics can help because, for example, Da Vinci already has this on their platform. You can practice techniques and practice steps on the robot. So I think, a lot of the challenges in training are skill acquisition and repetitive skill acquisition, and then transferring that to then sort of further more complex techniques.
Okay. So how is it like then when you are training medical trainees, whether they are actually doing medical examinations or in robotic surgery?
Okay. So I suppose there's two parts to that question. One is the medical students with clinical examination. So again, that's very labor intensive at the moment. So that means you'll have a patient, one expert doctor, and maybe a number of medical students, and then you're teaching them how to take the history. So ask the questions, get the answers, how to interpret that, and so that's again it's a very expensive apprenticeship, if you like, and it's very labor intensive. So you could transfer some of those things to computer-based or robotic-based platforms. So for example, a patient that can be programmed as a robot, a robot that could be programmed to be a patient, or even just a tutor to run through questions and answers, because there's a lot of algorithm-based thinking in medicine. So for example, if somebody comes in with, say, abdominal pain, there's a series of questions that we ask which sort of tell you about the patient, and a series of questions that tell you about the problem or the pathology or the question. So you could use a robotic patient and to simulate a condition, or again, you could have an interaction with a robot where the student will say, well, you know, why have you presented? And then there's a number of outcomes to that. In surgery, it lends itself extremely well because the robots, if you like, and whether they're tele manipulators or whether they're true robots or whatever, are very good at doing repeated specific tasks over and over again, which is a lot of what surgery is. So that's you know, again, robots, when you're trying to learn surgery, if it says, okay, well, you have to pick up this thing and move it over there, and how do you do that and learn to talk, I think that's where it would really come in handy. And I've certainly seen that even amongst my older surgical colleagues who learned the Da Vinci robot, when they try the simulators that Da Vinci has put together, it gives them quite a lot of skill acquisition very quickly.
Right, that's great. So when training with medical trainees, especially say in medical examinations, so you mentioned that it's been pretty labor intensive so far, and the training is mostly performed on an actual patient. So how do you usually recruit patients to come for trainings like this? And how's the interaction like between the trainers and also trainees with the patient?
Yeah, so that's an excellent question. So there are some scenarios in which you actually have professional actors or sort of people who professionally do this to simulate patients. So that's one group, but more commonly, the patients are actually patients in hospital already who give their consent. So the consultant physician or surgeon has asked the patient, can these medical students talk to you and examine you? And most often that happens in Australia within the public hospital system. So a little bit like the UK and probably sort of similar to the private system in the US, where the patients are admitted and then their permission is obtained and then a history is taken. Now, the difficulty with this is that common things are common, and you will see those common presentations, you know, frequently in the hospital. But the uncommon things, which is what you want to try and get a lot of exposure to as a medical student, you may not come across that, right? So here's a way, using some sort of computerized or robotic platform, where you can program those very rare conditions and try to find, you know, sort of teach them how to take that history and examination. So at the moment, again, it's just dependent on where you are and what sort of patients come in. So an example would be in winter, there would be more pneumonia patients. You know, in summer, there may be more trauma patients, you know, this sort of thing. So that's currently how they're taught. So that's in relation to the medical students. In terms of the surgical trainees, well, again, they're only exposed to what they see in the operating theatre or what's placed on a list. The other problem that we have in Australia is that we have a split public-private system. So the cases that are seen in the public will be most of the cases, but there's a lot of stuff that just happens in the private sector, of which then the trainee doesn't get enough exposure in the public. So again, some sort of robotic model would help. Yeah.
Okay. Yeah, and that's there's also like variables such as the gender, the age, and then the diversity stuff with the patient going on.
Absolutely. So depending on where you are, the age, the as you say, the gender, their health problems, their access to care, all of these things are variable depending on where that hospital is located.
Okay. So yeah, so you have mentioned that robotic assisted training technology would support like all these challenges that we're facing at the moment in medical training, especially for examination, which is probably lacking at the same time. So so besides training on patients, are there any technology support that any clinicians have been using so far, like the ones that you have tried before or the ones that you know?
Yeah, look, there are. So I guess if I look back to when I was a medical student, the majority of what I learnt was actually still from textbooks and journals. And then, so that was in the 90s and sort of the early 90s. Then when I became a junior doctor, there was obviously the shift towards internet-based acquisition. This is just knowledge acquisition. And so now we come to 2020, and so there's internet-based things which are sort of adjuncts to, or they're things that assist knowledge acquisition. So, for example, there are many ways in which you can search information. And an example of that is the search engine. So this, again, is not exactly robotics, but it's more from a computer point of view. So I now do not buy any textbooks. I don't buy any journals. I just use the libraries through the College of Surgeons, and they can do summon searches and get you the information they require. For the medical students, again, there are online tools that they can use, which are sort of virtual in nature. So virtual anatomy, virtual operations, virtual clinical situations. The other thing that is now much more prevalent is that when you come across a clinical problem, you can actually, on your smartphone or the computer on the ward, find a lot of information and put together a sort of presentation and simulation. Other things that have changed are obviously the use of robotics, three-dimensional printing, so models that can be printed that medical students can practice on. So yeah, these are sort of how things have evolved. But you know, I think if you ask me what's the key, what does a medical student need to learn, or what does a junior doctor need to learn? It's to learn a system of acquiring information. So that is a system of taking a history, examining the patient, a system of interpreting investigations, and then a system of putting that all together to make a provisional diagnosis. And that's where sort of computers or robots come in handy, because they can narrow things down. For example, at the moment, I'm not sure whether you're aware, but in colonoscopy, where we put a camera up the bottom and around the colon, there are computer programs that will look at those images, and they will have a very low threshold for picking up abnormalities. So they might pick up 20 things that are abnormal, and then the colonoscopist now then looks at that 20 images and picks out the ones that are the problem there. So it's if I go back to the medical student and the junior doctor, it's learning those patterns. And then in particular in surgery, once you've learned the clinical part, again, it's learning those patterns in surgery to then do parts of it. And where I think we really ought to go is there's a concept I call cognitive overload, right? So I really firmly believe that, you know, you wake up in the morning, you're fresh, you have your coffee, you do your work, and then there are only so many things you can do in one day before you get tired or distracted, or you're not working at peak performance, right? So for example, I know I always try and finish my operating list by 6 p.m. at the latest, because a few reasons. At 8 p.m., I'm not going to be in exactly the same, if you like, same energy level at 8 p.m. that I am at 8 a.m. if I've been going all day. Secondly, my team is going to be tired, and so on, right? So the reason I bring that up is because if we can get things that help minimize our cognitive effort, whether that's thinking or doing, it'll help us. And a classic example of this is GPS in cars. GPS in cars make you able to drive from point A to point B and do something else at the same time. Whereas, you know, not that long ago, we'd have to read a map, stop, think, you know, where am I going? So I think it's sort of, you know, robots will help with all of that. Like, for example, the Da Vinci robot will allow me to, if it's a difficult point, just to stand up from the robot and nothing moves, everything stays in position. Then when I sit back down, I can continue operating exactly the same, instead of having to take all the instruments out, reposition everything, and so on. So, yeah.
Yeah, that could really help with fatigue issue among the doctors.
Yes.
Yeah.
Yes.
All
Yeah.
right, interesting. So, do you have any wish list of technology that you would like to implement in, like medical training?
Yeah. So let me start, I suppose, going backwards from where I am now, and then I'll go back to the training. So if you said to me, what things would make my job easier, would make patient outcomes better, and overall allow us to progress? It's quite simple. Like if I think about it, when I go on a ward round, if I can have a almost like a digital robot / assistant that comes around with me, and then I say to them, listen, check the bloods at 11 a.m. I know this all sounds really silly, but check the bloods at 11 a.m. and tell me what they are. Or you're giving them a whole series of tasks that they register, and they can deliver back the information that you want. Then your brain is again freed of that, right? So
actually
then when I go,
not silly at all.
yeah. So then if I go to the operating theatre and then just say it's a new team, there's 1 or 2 new members, well, again, I have a robotic assistant or at least a computer that can tell them, look, this is how he positions the patient, this is the map, this and that, like you don't have to sort of repeat everything. Then during the actual operation, as I said, if there are things that help us with both physical, to decrease physical fatigue, to decrease physical sort of activity and mental activity, that would help. See, I'm in my mid-40s, and so I'm a young surgeon, but you'll find a lot of guys in my profession, by the time they say 60, 65, they will tell you, the muscular sort of a strain and tension is quite a lot more when you're 65 than when you're 45. So again, robots to sort of assist with that. And then the other thing from a wish list point of view would be acquisition of imaging overlaid on what I'm operating on. So we have some of that already in some form, but really when you come to a difficult technical part, if I'm relying more on other senses just than vision and touch and haptic feedback, I can operate more safely. An example being a revisional, say, bariatric operation or upper GI operation where you can't see as well. And if you could get some cross-sectional anatomy that you can lay over what you're seeing, and you can see in 3 dimensions, right? There I am, I'm too close to the crus, or I'm too close to the vagus, or I'm too close to the big vessels or whatever. That would help. So that's where I think the kind of robots come in. I don't think some surgeons and clinicians worry that robots are somehow going to, take over their jobs. I don't think they're going to take over their jobs. I think they're just going to augment what we do. If I go, then I sort of go backwards from where I am and I say, okay, with training, again, if I'm to train somebody and I can send them a little virtual kind of video or whatever of how we do it all, that will help their skill acquisition. And then if they're doing the procedure and they fall outside of some parameters, then again, a warning, right? So again, simplistic example, but you can, cars now, if you go outside of the lane, they'll give you a warning. If you're too close to the car in front, they'll give you a warning. These are the things where we could do some parameters around. For argument's sake, again, say you're doing a fundoplication and the inferior vena cava is off to your right. If you could have that imprinted, so if your instrument strays a little too far out of there, then you get a warning. That's a really sort of, something that's again helpful for training. Going back more, I guess, with the medical students, then again, it's skill acquisition, and they can acquire the knowledge at their own pace and rate. So I think we're all understanding that gone are the days where you put somebody in one class and they go to the next class, the next class, so everybody learns at different rates. So I think having some kind of even robotic patient to sort of practice on, that they're all helpful things.
Okay. So yeah, speaking of like the different learning rate and all. So yeah, just a question to that add on to what we have discussed earlier. Like when you're training, you have like different perception, different sensitivity to like feeling of desired target within the abdomen. So how do you actually communicate with the trainees to actually, you know, get the sort of sensitivity? Like, yeah.
Yeah. This is a really interesting point. So over the years, you know, there is a spectrum, like in everything else, right? There's a spectrum of how quick people acquire. So, for example, if you say to me, "How do I know that that instrument I'm grasping it to the tissue too tightly, or I'm putting it on too much tension, or the kind of extension of that is I'm going to cause damage?" That is a whole lot of signals that come back to you. So one is the haptic feedback you get through the instrument. So already that's muted because it's on the end of that instrument. It has to travel through the grasper to your hand. The other is the vision. The vision gives you so many pieces of information. So for example, if you pull the tissue and you can see that the fibers are sort of on tension or strain, you realize that's a little bit too much. Or if you've grasped the tissue and it's now become white because there's not enough blood supply to it, that's another indication. But you see, this is the thing about the learning. Somewhere you've got to pick that up. So the way we did it as trainees is the surgeon would be watching you and say, "Listen, that's too tight, you know, too hard. You're pulling too much," whatever. And then you slowly learn it. The interesting part to that is that tension that is the appropriate or accurate tension is different in every patient and every pathology. So you may get a 70-year-old with very thin, friable tissue, or you might get a 30-year-old that's very robust tissue. So again, different strengths that you're using to manipulate that. If they've been on steroids, you know, all these, or if there's a lot of inflammation or they've had previous surgery, these are the nuances that I think is hard to teach. And then again, that's the thing that's going to be, I think, difficult also to translate to robotic surgery, because I'm sure you'll be able to do it, but in some way we'd have to videotape, you know, tens of thousands of operations and try and get the computer to interpret it in some AI way. But I think there are some devices now where, for example, with stapling, so the Da Vinci has one, and I think a few of the other companies, but basically they sense the tissue and then they sort of compress at different rates. Now, this is good. I like it. I don't know how much evidence there is that it makes any difference. That's the other thing. So we know that they're saying, okay, this is thicker tissue, I'm going to fire this. And obviously it's still about the end point. But it's, you know, I think yeah, they're the sort of points that I really make there.
Yeah, especially with so much diversity going. Yeah, similarly for medical examination as well. I believe it takes a lot of experience to really get there.
Correct. And I think this is the thing that I've only realized in hindsight is that the reason it takes so long to train, and particularly in surgery, is you do need somebody there to guide you. It is a true apprenticeship to teach you what is the correct thing, and then off you go after that. You can't do away with time and caseload. You end up being not adequately trained.
Yeah, so it's useful to have like, or actually important to have feedback along the way as you train. So in terms of like the implementation of robotics technology into training, we can implement feedbacks, for example, force feedback, haptic feedback, or even like in robotic patient, verbal, visual.
So the feedback, the haptic feedback thing is really the thing that we need. So there are a few other platforms out there as well that have that, but again, all of these things are in the infancy. But absolutely, they're the key. If you can see well, if you can feel well, You know, I think they're the key two things to be able to get some more feedback. So, you know, there's nothing beats you know, feeling the tissue. So you'll find, I mean, another thing is, for example, in surgery, that we wear single gloves or double gloves. So people, you know, often wear double gloves for protection. And a lot of surgeons will say, look, they only like to wear single gloves because you lose the sensation of feeling of the tissue. So, you know, I think haptic feedback in robotics is very important.
That's great to know. All right. So, yeah, I guess we're coming to an end of the interview. And so, Dr. Dan, do you have anything in general that you would like to add?
I think this is my view as somewhat an outsider to the more of the engineering and the robotic side, but I think in some respects the technology is there. So, for example, when I talk about lane warnings on cars and visualization and haptic feedback, it's just trying to put that all together in a platform that we could use. And I think that would, you know, and if it was in a cost-effective platform, we could certainly do wonders from that point of view, because I think they are all just aids to help us perform things more easily. The second part is that overlay of the imaging on top of the operative picture. That again would help immensely. I think, you know, being able to have that, in a way, it's an additional sense of vision. So it's a different kind of vision. It's using the X-ray vision along with your normal camera vision. That would certainly help immensely. Yeah.
Right. So, yeah, it's been a really insightful conversation. Thank you so much for your time and for all the information you've given. And well, we look forward to chatting with you again really soon.
Thank you. Thanks, Florence. Thanks for having me.
Thank you.